Ready. This patient is status post laminectomy, severe spine osteoarthrosis, history of sciatica bilaterally. So did well with surgery, had a flare-up, is back to feeling better, and this is how we are going to approach treating this patient's lower back to improve function and reduce pain. I can notice a scar here. And we're going to start off with some instrument-assisted soft tissue mobilization. We're going to use a metal instrument, analgesic lotion, and we're just going to work around the scar area. The object is to break up superficial fascia. It's also very stimulating. It can help disperse any inflammation around the area. It stimulates connective tissues like sacral multifidi. And by stimulating tendons, you get increased fibroblast activity, which can improve tendinopathy, this we know. And this is passive right now. The patient's lying still and I'm doing the work. And we can change it up and make it a little more active. I'm going to switch instruments. So if you would, extend this hip just a little bit, lift it up. This is also an improvement. He couldn't lift his leg at all last week.
Move the right leg.
Oh, yeah. And then lower it down. Let's do the other side. And lift. There you go. You get a little bit of movement. That's good. And lower it down. Switch. So we're just engaging. We're engaging musculature while we're doing instrument-assisted soft tissue mobilization. Good, and switch. Yep, and really focus on squeezing your glute really tight.
That's the bum leg.
That's it. And switch. And relax. Normally this would go for a few more minutes, but for demonstration purposes, we're going to stop it right here and switch gears. Now what we're going to do is very light decompression. It says hands-on decompression. And hold on to the ankles. Table is disengaged. Now, normally, in a non-surgical back, I would hold down one bone and pull the other away. But with a post-surgical back where it may be pretty sensitive, I'm going to focus on soft tissues more than vertebral decompression. So I'm going to hold my finger on his spine here, both sides. I'm putting a lot of pressure on the spine, and I'm just going to axially distract and slowly, easily create a little bit of trunk flexion while I keep a firm press. Now, the beauty of hands-on spine decompression versus tables where a patient's harnessed and just kind of left on their own is I can feel what's going on, and if there's anything that's really irritating, his muscles will react and kind of spasm a little bit against my fingers, and usually that's a sign that the treatment's not a good idea. Need to switch up and do something different or back off in some way. So far so good. I'm able to get a little bit of distraction. I'm able to push pretty hard into the muscles. I'm above the surgical lesion, and I can get a little bit of vertebral decompression. I'm going to attempt changing my hand contact, a little more axial distraction, good amount of force, and a little bit of flexion. And that feels okay?
Mm-hmm. Definitely, working that disc, I can tell.
Yeah. Okay. And you get the idea. That's typically how we work in this situation.